I have a little model here. And if you can see with the model, what we're going to do, I have zygomatic implants here. Okay. So they go up this way, zygomatic implants. And we're going to also show you regular sinus. Now, every general dentist should be doing sinuses. Every dentist should be trained in doing sinuses so that when you're doing an implant, sinuses are not your barrier, right? Obstacle, rather say. Zygomatic implants are a whole different animal, and you need good training for that. And I can always recommend courses because, other courses you have to take as many as possible so that you can become who you want to become, which is a great practitioner, right? So I'm going to show you that. Let me go take you to the slideshow right away. So this again, I call ourselves a Long Island Maxi course, LIMC, which is called LIMC. And LIMC privileges means that when you join our group, you can use this Yomi robot whenever you want. I don't have to be here. Our team takes care of it. Just like you're going to a hospital with privileges, now you have an office with privileges. So I'm going to go through these slides quickly. It's about soft and hard tissue considerations. And what we're going to do here is, just to give you an example, we have a patient. This is typical when they're missing a premolar and a molar on the upper side, left or right, doesn't matter. But if you look at this, they have soft tissue loss. So soft tissue, hard tissue. So we have to control that. When we're going to do this, we have to make sure that we plan this out correctly. So sure, we're going to place 2 implants in this space, but look at the soft tissue. The soft tissue needs to be addressed also. So it can't just be placing implants. You also have to learn about perio. Once you start doing perio and you start doing bone grafts and hard tissue, soft tissue, you're definitely going to be the person that people want to go to. And the years of experience and taking courses and lectures is what's going to make you that better practitioner. So I'm just kind of showing you the deficiency of bone there. Look how much deficiency there is there. It's a lot. And so we're going to need to know about membranes, whether they're going to be resorbable, non-resorbable, what kind of graft you're going to place there, since we're doing a sinus, block grafts, particular grafts. There's so much to do. This is days and days of lectures. Incision design, which is obviously part of the soft tissue management, right? So there's a lot to go through here, and there's a lot of slides that we're going to be skipping through a lot. But this is the sinus that we see here. This is typical of what you see in an office, all right? The whole dark area is your sinus. The whole area there below it is your crest, and obviously they need a bone graft. We need a bone graft here because we have to put implants into a stable structure. So what do we do here? All right, so I usually have questions on my slides, but since we're going to go fast on this, the normal case for implants to be done are we have to do a sinus lift, either lateral wall or crestal wall, which means we approach it from underneath. I'm going to see if you can see this over here. If we're going to do a crestal approach, what happens is that we're going to go from underneath the sinus. I don't know if you can see it better over here, underneath the sinus. So this would be the sinus area. And then you would have to do a crestal approach, which is very difficult to do. You have to do that with some training. Or we're going to do a lateral wall, which a lateral wall is when we go in here and we make a little window here. And when we do this window, when you see this window here, we actually go into the sinus. And I'm going to show how it looks on the inside. If you can see on the inside, you can see how it pops out there. Are you able to see that? So when you see that, that should be the sinus membrane. And you have to be prepared to graft. And if this should tear, you have to be prepared to manage the situation. So it's not just doing a sinus and then I'll see you later. This is called the window. These are sinus lift instruments. I'll show you a little bit more. So this procedure here, we fill up the sinus with bone, with graft. We have to wait 6 to 9 months, depending on the person's health. If we do a zygomatic implants, that's immediate. We place the zygomatic implants. We're going to use the pterygoid also, and then now we can load it right away the same day. Those are the benefits. This is over a year and a half. This is immediately. Okay. So, but obviously you don't want to do this all the time because if they have enough bone, you want to use their bone. We're going to go forward with more slideshows. So these are the placements of the implants like I'm trying to explain here. The deficiency of bone, the soft tissue we have to pay attention to, the incision design, where the implants are going to be placed, what kind of bone we're going to use. All this, like I said, all this comes into play. You're not going to learn this in one class. You're going to learn this over courses, many, many different courses. So this is called a pneumatized sinus. And we also have arteries here. So when we look at these arteries, we have to be careful. And this is what teaches you how to read a CAT scan. We call them bleeders. Why? Because if you go make a window in this area, it's going to bleed all over the place. And you don't want to do that. on your first sinus. All right, you have to be trained for this. So this is the plan with an older CAT scan machine. This is our sinus that we did there. It looks like we did a lot, but I know if I'm going to do a sinus lift, a lot of times doctors will tell you, oh, you just have to put a 10 millimeter sinus. But if I can control the height of the sinus, because I'm going to do a lateral wall anyway, so I like to put a longer implant, 11 and a half, 12, whichever your system allows. But there's no need to put a 16 millimeter one in that, okay? So you're going to raise it probably about 12 to 14 millimeters because you always get some resorption. So as we go forward, this is what it looks like. And this is what it looks like on the crosscuts, right? And this is what the implants look like 6 months later. That's what we did. So this is where the plan is. Where I usually use a Thompson stick to mark that. I like to use my Calderón instrument that I showed you beforehand. This is for spacing, Calderón spacing implant spacing instrument. And we use that to reflect everything and also do our surgeries. So I like to do a little osteotomy first before I do the incision design. If you can see the incision design, it was just like the drawing I showed you. That's the path. And so when I do these little osteotomies and I reflect that tissue, now I can reflect it and then I'll see what it looks like. This is papilla sparing. I can see exactly where the bone, the osteotomies are going. Implants are going in there. They're all spaced out properly. Now we have to decide how we can close this. Do we close this with primary intentions or secondary intentions? If you guys remember what that means, either do we put the tissue together or do we leave them apart and let it heal slowly by secondary intention? We want to try and do everything primary. But how are we going to do this? By putting something in between implants. And everybody kind of learns the Palachi system or method. And that's what he did. And they make incisions on the side that has the most connective tissue, and we put it in between the implants. Now, this is important to learn. You have to practice on a model because the first time you do it in the office, it's going to be messy. You have to really practice on a model, please. All right, look at the way it looks. It looks messy there, right? And today I'm better at it, and you're going to use thin sutures. Today I use PTFE instead of Vicryl, but that's the way it looks. Now, lingual to those implants or palatal to those implants, that's going to heal by secondary intention, meaning that there's not no primary closure there. The papilla in between the implants is going to form by me passing the connective tissue. That's the way it looks. It looks like really like a hamburger, but it does heal. We have to just keep an eye on the patient, and that's where it's healing. This is an older case, but look at all that beautiful thick tissue we have 2 to 8 weeks later. You got 2 weeks and then 8 weeks. So it granulates in, and this is what you want, because when you have connective tissue there, it's going to keep the implant healthier by not allowing resorption of the bone. This is an older system, so today I would use scan bodies, and this is the way the implants were cemented beforehand. Today I would use zirconia instead of PFMs, and that's the way the implant system looks. What's my mistake here? I could have used pink porcelain. Also, if you look at the tissue pool there, there's a what do you call that? A frenum, and the buccal frenum is always going to pull on that tissue. So I should have done a little frenectomy, right? But you learn these things as you go along, right? As long as somebody kind of just mentions it, you'll remember it. Okay, and this is how it goes. So I'm showing you the muscle pull there with the frenum. And once again, I'm always going to show you this photograph because every morning before you start your day, sit down, have a cup of coffee, regroup your thoughts, and you need to know what you're going to do. All right. You always need to know what you're going to do. And remember what I told you, never give up. Let's come over here to show you with the models again. So now what happens here with the models, if you can appreciate this, on this sinus lift kit, it comes with a little dome here that I'll go in here and I'll start to relieve the soft tissue this way. And as we showed you before, I'm sorry, I'm going to stand up for this. It pushes out the tissue this way. Okay. So this would be a lateral wall sinus lift. Once we add bone there, we can actually measure this with this instrument. And if we measure it this way, you can see that every thick line is 5 millimeters. So that window from coronal to apical area or inferior superior is about 7 millimeters. Medial distal, anterior posterior, it's about 11 millimeters. All right. So when that window, it doesn't matter how small the window is, you kind of want to make it wider. And my the people I learned from, somebody like Carl Misch, he always said that, whenever the bigger the window is, the better you can see, the better your surgery, because no matter what, it's going to heal. So don't try to be so conservative and make a small window, because it's going to be sloppy. You're going to tear the membrane. Something's going to happen in there. Let's just do it right. Look at it, because surgery is about visual. You got to be able to see it. All right. So I wanted you to see this, appreciate it, because you can do lateral wall inferior lift, or you can do zygomas. And along with zygomas, you have to add something called a pterygoid. Now, if you see this pterygoid implant being placed here in this model, this is how I learned. And it's coming through. These are the lateral pterygoid, medial pterygoid plates. It came through the medial pterygoid plates. You don't want that. You want to aim for the middle here, in between the plates, right? And I mean, this is acceptable, but in between these two plates, it's what's best. And that's where you start using the CAT scan. You can use guides, or you can use the Yomi robot for that. The Yomi robot works fantastic because everything is done the same day. So if somebody comes to me in the morning, says, I want to get this done, pre-medication, we start the workup, we connect the Yomi, CAT scan's done, I do the treatment plan on the CAT scan, and then all of a sudden the Yomi's doing all the work for me. So Yomi is a great investment. If you're going to do a lot of surgeries and, things that are technique sensitive, you need to do that. Next, I'm always going to tell you this on every lecture, gross anatomy. You have to take a gross anatomy course no matter what. Take it every 3 years, maybe every 4 years, whatever you can. Refresh your mind, because obviously if you're an oral surgeon, you don't need that because you're doing that every day. But you need to do this so that you can be fresh at your fingertips when you're working on someone. We have a cadaver course that's coming up, and ours is in November. So if you want to join us, it's on the Calderón Institute. I don't remember the dates, but you can always call us. I believe it's November 1st and 2nd. Let's see. It's November 1st and 2nd, and it's a Friday, Saturday, and a half a day Sunday. You come join us then. You have to register early though, because we have to get the specimens and we have to respect the bodies. And to get these specimens, is normally 3 doctors per specimen. So if we have 12 doctors, we need to get 3 specimens. All right. So you can give me a call. This is my cell number, 516-852-1386. I'm open for questions. You can call me anytime you want. You can text me. You can do anything you wish there. Okay. Just never give up. Everybody, peace out. I'm Implant Mike on Instagram. Ciao.